ورجعنا لكم تاني في حلقة جديدة من بودكاست بالسكر. وأنا النهاردة في مؤتمر الجمعية الأوروبية للسكر لدراسة سكر ESD 2024، وده بالمناسبة المؤتمر رقم 64 للجمعية. معايا النهاردة أستاذي بروفيسور رياض مالك، أستاذ السكر وأحد كبار مؤلفي ومؤسسي علم التهاب الأعصاب السكري في العالم، والراجل ده فعلا هو اللي علمني التهاب أعصاب، وكتر خير وافق إنه يطلع معانا في هذه الحلقة. Good morning, Professor.
Assalamu alaikum.
عليكم
Good morning.
السلام. Good morning. Okay, so will you please introduce yourself?
So it's me, Riyad Malik,
Yes.
Anna Tabib, and there it ends. So now I'm Riyaz Malik. I'm professor of medicine in Weill Cornell in Doha, Qatar, consultant physician, endocrinologist in Hamad hospitals.
Okay, and would you please tell me what are your newest researches?
Okay. So that's a loaded question, but
Mhm.
uh, in short, actually, my focus of my research for 30 years has been diabetic neuropathy, which is what I call the Cinderella complication. Why the Cinderella complication? Because a lot of people ignore it or they don't really look for it because of this, what I call a nihilistic view of diabetic neuropathy, which is, so what if we diagnose it? What are we going to do for it? Even the treatments that we have for it aren't that effective. So there's this very down kind of view of diabetic neuropathy. So really, the challenges that we have, I think, relate around being able to diagnose the condition better. And that doesn't mean necessarily, I will talk about tools, that are kind of really advanced, but actually
Okay.
diagnosing it using just simple questionnaires, right? Because what we've shown actually across the Gulf region, especially, is that up to 50% of people, 1 in 2 people, are not being diagnosed with diabetic neuropathy. And that, I think, is a major issue that needs to be addressed. And we're actually working together with some companies, you might say, but to try to have an easier method of diagnosing, which changes the paradigm. Usual method is that what you do is you sit in your clinic and you don't ask the question, and the patient often doesn't really relate what they're having in terms of symptoms for neuropathy to diabetes related complications. So nobody diagnoses it. We're trying to change that paradigm to say, okay, let's have the patient, let's somehow get the information to the patient, and the patient does a quick questionnaire, right? It takes them like literally 30 seconds. They then come to you and say, doctor, look, I've just done this questionnaire and I think I've got neuropathy. You need to now do something about it.
So basically, what you're saying is that the general setting, which I totally agree with you, is we wait for the patient to come over and tell us, Doctor, I have neuropathy.
Yeah.
Okay. And then after the patient says, Doctor, I have neuropathy, then we start looking into it. But if the patient doesn't mention it, generally speaking, the doctor doesn't look for it. Generally speaking.
Not generally, actually, the majority of the time we're too busy. Why is it that we focus on HbA1c, on lipids, on blood pressure? Because these are measured things that are available to us, information in front of us. Even retinopathy, like we maybe not as much in our part of the world, but there is in UK, US, there is formal retinal screening. So people you have the information in front of you, deal with it. If you don't have the information in front of you, you haven't got much time to deal with this.
Okay.
You don't.
Okay. So next comes the next question. This was your latest paper, which I've already seen your presentation about.
Yeah.
Okay. And how do you measure neuropathy?
Okay, so neuropathy, of course, you can measure in the clinic from symptoms, but that only affects maybe 30% of people, positive symptoms. I'm talking about pain.
What's positive and what's negative symptoms? That's
Okay,
a good
this
question.
is very important.
Yes.
So the positive symptoms are those that the patient feels in terms of they get pins and needles, they get tingling, they get ant-like crawling in both their feet. It's worse at night. They can't sleep. So those are positive, okay, and that actually will bring the patient to the doctor, perhaps. But the negative symptoms, which are actually the worst, I think, because it means they don't feel is a problem. They actually lose sensation, and those are the things that lead you to develop an ulcer, and you don't know about it. And that is
ulcer is diabetic foot.
Yeah.
Okay.
Diabetic foot.
My question here, I think you see this as much as I do. You ask, as I'm sure you do,
Yeah.
you ask the patient, do you have any pain in your feet or anything of the sort? And the patient tells you, yes, I used to have this terrible pain, but now, thanks God, it's gone.
Yeah, exactly.
How do you feel at this point?
I think, oh my God, they've now progressed to advanced neuropathy, and this is where it's really difficult.
Okay.
And I think it's an opportunity. People say to me, well, do you need advanced technique? I don't think so. I mean, painful neuropathy actually is telling you, yes, you can have pain towards the end, but really it's the early stages of disease. And it should alert the patient, should alert the physician to do something about it, not just give tricyclics or gabapentin or pregabalin to deal with the pain.
These medications you are mentioning
Mm.
are actually painkillers and
Yeah.
nothing more.
Exactly. They don't treat the underlying disease. And again, we have to have a positive view of we can treat neuropathy. And we've now got data using some very sensitive techniques. One particular one called corneal confocal microscopy, which I will talk about.
Yes, your invention.
Okay. But I think I was in a position 20 years ago where I was introduced to it, and actually I didn't kind of have a negative view about it. I had an open mind, and that's the most important thing, that I can really measure nerve damage by looking at the eye instead of the foot. It was like a crazy idea. People actually initially, when I did the first bit of work, people thought, this guy's an idiot. He doesn't understand diabetic neuropathy. Alhamdulillah, things have worked out okay.
Alhamdulillah. So the first step in treating anything is a proper quantified diagnosis. Would you agree with me?
Absolutely. I think we have to move on from what I call even prehistoric ages or the dark ages, where we relied on subjective assessment of the patient. They have a place, right? But I can't deny that, a neurological exam or reflexes are a good way of assessing neuropathy. But what stage of neuropathy?
We have to first determine the type. Like, is it a spinal cause? Do I have an entrapment somewhere, like a tarsal tunnel syndrome or myalgia paresthetica? Or is this DSPN? Or is this diabetic amount proximal asymmetrical neuropathy? This can only come out first by diagnosis, first by clinical examination.
Clinical history and appropriate examination. However, it will not pick up the majority of neuropathy, which starts actually, we know now, even in children.
Yes.
Even in people who've got impaired glucose tolerance, pre-diabetes, already they have early nerve damage. In those patients, we kind of think, it takes 10 years, maybe 15 years for diabetic neuropathy to develop. And what I believe we need is objective techniques which can pick up that disease early.
Mhm.
And it's a disease that actually is also in our heads. We need to know that there are small fibers, there are large fibers.
Okay.
And it is the small fibers which
we're talking about small
early.
nerve fibers.
Nerve fibers.
Large nerve fibers. Okay. What's the difference between a large nerve fiber and a small nerve fiber?
One simple difference is that actually in a nerve, 90% are small fibers. And actually, I often say in a joking way, God put them there for a reason. Why made them more 90% rather than 10%? That is because they serve lots of functions. Okay. And those are, they mediate pain. They actually mediate sweating. They mediate sensation, of course, pain sensation. But also they actually are, we do not, a lot of people don't realize that they regulate blood flow and inflammation. And they actually are much more important for the development of a foot ulcer than any other fiber, and yet we completely ignore them.
Okay, this is functionality wise. What about structure wise? Like a large nerve fiber is something you can actually see with your eyes.
No, large fiber is basically is a nomenclature that we use. It is bigger in size. It has a
Nomenclature
myelin.
means the naming.
Yeah.
Okay.
It has a myelin sheath, whereas
Mhm.
unmyelinated fibers are much smaller. They don't have a myelin sheath, and it's
Okay.
to do with the how quickly the signal passes
Okay.
through the nerve.
Okay. But I can measure large fibers using nerve conduction studies,
Yes,
but I cannot measure small fibers using nerve conduction studies.
correct.
Okay. Which puts us in a big problem because the actual assessment, we previously used to rely on biopsies, which I take out a part of the skin from the ankle.
Yeah.
Okay. And then we see it under the microscope and determine what the nerves look like there.
Yeah.
Now, I believe this is a pretty barbaric procedure for the diagnosis.
Some would say minimally invasive, but yeah, I mean, to diagnose, I mean, you can't imagine a patient who already has diabetic foot problems and you're going to create a wound.
Yes,
you know?
exactly.
Yeah. This is not, and it certainly isn't widely applicable because even when you've taken the biopsy, you have to take it to a specialist lab who have to do specialist staining.
And takes a week
yeah,
or more to.
Much more. And it's actually quite variable.
Okay. So that was the old way.
Yeah.
Okay. And then we have, after that, we have one step in the midway, which is pseudoscan.
Yeah.
Okay. Which does not actually measure small fiber neuropathy,
Yeah.
but measures the byproduct of its function.
Mm-hmm.
Okay.
A proxy.
A proxy.
Yeah. Yeah.
Okay.
So
it gives us a fair idea about how things are going
yeah.
without actually having to make a hole inside the patient's foot.
Yeah.
Okay. Then came CCM.
Yeah.
Tell us about CCM, your invention.
Okay. So but going back to pseudomotor dysfunction, honestly, I will say to you, pseudoscan has its strengths and weaknesses. The major strength in pseudoscan is at least you are measuring something.
Yes.
Otherwise, we're ignoring these small fibers completely, right? So yes, we all know that there is variability and interpretation difficulties, right? But at least we're measuring something, right? Now, when it comes to CCM, corneal confocal microscopy, in a simple way, what I want to say is that this is an eye scan.
Okay, so basically the cornea is the outer part of the eye.
Yeah.
The part you look through.
And I always say to people, if you want to assess whether a nerve is working or not, normally what you can do is you can do this, okay? And you feel a little bit of a touch. Honey, now just take your glasses off for me. Would you like me to poke your eye, huh? See how Honey moves, right? So that in itself just tells you, right, that how sensitive, how many nerves there are, these corneal nerves.
This is a wonderful illustration. I never thought of it.
Okay. So then what you have to say is, Honey, do you mind if I biopsy your cornea? No. Of course you say no. Don't be stupid.
I wouldn't even think about that.
Yeah. So instead, what I'm offering you is corneal confocal microscopy, which is actually an ophthalmic eye scan, which it does touch the front of your eye, but that's it. And within 2 minutes, I can actually have pictures of nerve fibers. And if I have pictures of nerve fibers, what does it mean? I can measure them. I can quantify them. I can say there are X number of nerve fibers, and I can measure them now, and I can measure them over time. So there's actually several, I would say, pluses here. One is I can measure it. Two, I've got a picture to show my patient. There is nothing more powerful, honestly. I can tell you in my clinic, when I've got a patient in front of me and I say, oh, you've got neuropathy. They say, oh, okay, doc, I've got neuropathy. When I show them, you've got, instead of this is a healthy control, should have 8 nerve fibers, and you've got 4 nerve fibers. They go, whoa, really?
Where did the other 4 go?
Yes, I need to do something about this. Then what I do is I say, okay, we need to do the following things. We need to improve your glucose control. We need to maybe, put you on.
So before we go into treatment, first I wanted to ask you, in order to do this, is it a widely available device?
So that is an issue, and an issue that Heidelberg need to address. So this
Heidelberg is the company which makes
makes yeah
the equipment.
yeah. So
Okay.
at the moment, actually, there are probably about 3,000 devices across the world, maybe more, 4,000, because the
Okay.
Chinese have bought a lot of them.
And not all of them are used for this function. It is basically an ophthalmological device,
Yeah.
which we as diabetologists and neurologists concerned with neuropathy,
Yeah.
we have taken and used it in a different function.
Yeah.
But it was originally made for pure ophthalmological reasons.
Absolutely. I mean, it was used to image the cornea. And actually, believe it or not, one of the major reasons why it's still being bought in China is it's good for acanthamoeba infection.
Acanthamoebas.
Right?
Mhm.
Okay, so amoeboisis. So like acanthamoeba infection, before you have to do something called corneal scraping, right? Where you scrape the cornea
That's horrible.
to get a bit of tissue, right? To then grow these acanthamoeba. But you could actually image with corneal confocal microscopy. And some people also use it for dry eyes,
Mhm.
for refractive surgery, but not really used for looking at nerves and nerves in diabetes. But also, we now have lots of data showing not just diabetic neuropathy, but actually multiple other neurodegenerative diseases. What are these? Dementia, epilepsy, multiple sclerosis, Parkinson's disease. Now we have the power with the corneal confocal microscopy to identify nerve degeneration. With AI, we can actually identify which condition it's coming from.
That's really wonderful.
Yeah.
Okay, so my next question here, as these devices are not come, like I know for a fact that in my country, in Egypt, we do not have one single device,
Okay.
which is something I really hope I can change
Right.
within the future.
Yeah.
Now, uh, if the device is there,
Yeah.
how expensive is the test, relatively speaking?
Okay.
And how much time does it take?
So the actual test, the only cost is something called the tomocap, which is the cover that you put on the microscope, and that's about $2.
Okay.
Okay. How long does it take? In good hands, 5 minutes maximum.
So it needs someone well trained.
Not really. I've got people who work with me who have no background in ophthalmology, no background even in optometry, or actually were scientists. They learned within a week, 4 days, 5 days, they can use it. And I always say, actually, people who are younger generation, who are the PlayStation generation,
Yes,
are
they're
much better at using
much
these things.
definitely much better than we
Yeah,
are.
yeah, yeah.
Okay. Now, next question. So now we have actually managed to diagnose neuropathy somehow,
Yeah.
whether it's by clinical examination, by pseudoscan, by vibration perception threshold, by biotensiometry, by CCM,
Mm.
by biopsy.
Mm.
Okay. And we have actually reached the diagnosis.
Yeah.
What do I do next?
Right. Okay. So actually, you need to go, I suppose, to evidence that's been around for 20, 30 years, which is that vascular risk factors are what drive.
Okay.
What are vascular risk factors? You're asking me. Okay. So
Definitely.
vascular risk factors are those things that we measure that are initially were related to my risk of having a heart attack or a stroke.
Mhm.
Okay. And what are those? Well, high glucose, high blood pressure, high lipids, being overweight, being less active. And we actually did a study across the Gulf region, which is relevant, right? Because there's no point me telling you data about from Europe and the USA. In the Gulf region, 3,000 patients with diabetes. And we showed if you have a longer duration of diabetes, if you have higher glucose, if you have blood pressure, if you are less active, if you are more obese, if you smoke, if you are a male, you have a higher risk of diabetic neuropathy.
Even if you're tall.
Yeah, if you're taller as well.
Mm.
Okay, so logically you'd say, well, then, okay, if you treat those risk factors, can you improve the neuropathy? And actually, not using any other technique, but using CCM, we've been able to show that now, that when we improve blood glucose, particularly, right, using drugs that lower glucose, but also lower weight. That's a key.
That's very important. What are the drugs which lower glucose, which increase weight rather than decrease weight?
So actually, the commonest used drugs, which is sulfonylureas, like glibenclamide, like gliclazide, like glipizide. These actually cause weight gain.
Yes.
Insulin causes weight gain.
Yes.
Metformin doesn't, which is why probably metformin is a little bit special. Actually, it's actually, even in big studies, always been shown to be beneficial, right? So those are the drugs that will be actually counter. Although they lower the glucose, they still aren't improving the nerves. Okay, whereas the newer drugs like the SGLT2 inhibitors, which lower weight, metformin, and the GLP-1 agonists or the dual agonists, where we really lose weight.
These are the injections for diabetes used by obesity.
Yes. Yes.
Okay.
So,
So with these drugs, neuropathy actually improves.
Yes. Yes.
Okay.
So actually we repair the nerves, we regenerate nerves, which again, something that 10 years ago we would have said, oh, never, we can't regenerate nerves. We're showing we can repair nerves.
Okay. Does this work the same for type 1 and for type 2 diabetes?
Yes, we've shown that. In type 1 diabetes, actually, with glucose control, we did pancreas transplantation, believe it or not, in Manchester, and we showed repair of nerves in really advanced disease. And that was another big key moment. I honestly thought people who are end stage never going to repair their nerves, but they repaired their nerves. So there's a huge
pancreatic transplantation.
Pancreas
So
transplantation.
we're talking about end stage neuropathy, which is total destruction of nerves. The nerves regenerated after pancreatic
transplantation. And then actually the other things that you can do to improve neuropathy is blood pressure reduction, but not even blood pressure reduction, actually using drugs that normally lower blood pressure, which improve blood flow. So ACE inhibitors, angiotensin 2 receptor blockers. These are calcium channel blockers even. There are two studies.
Beta blockers.
Not beta blockers, because they will do the opposite.
They'll do the exact opposite.
But so these have been shown. We showed it in a study 20 years ago that it improves nerve conduction even. And there are another Italian study which again showed this. And a drug that we don't use that much that has been shown to repair nerves, fenofibrate. Believe it or not.
Yes.
And we don't use it. We actually use it for hypertriglyceridemia, and we say we forget it, right? We use statins. But that actually is now, there is a lot of literature showing that fibrates are good, not just for lowering triglycerides, but they improve retinopathy, they improve microalbuminuria, and they improve neuropathy.
But doctor, don't lipid-lowering drugs cause nerve pain and muscle pain and bone pain?
They can, in a very small proportion of people, cause muscle pain, not nerve pain. There is very, very rare cases of what we call acute neuropathy. So the benefits that you get from these drugs far outweigh.
Yes. By the way, in my career, I have seen one patient.
Okay. And how many thousands have you seen? Hundreds of thousands, huh? Too many.
Too many.
Yeah.
Who actually had a statin neuropathy.
Yeah.
And that was one patient out of definitely more than 100,000.
Yeah, it happens. So but that's anything, you can walk across the road and a bus can run you over.
Exactly. Okay, so I'd like to thank you, and I'd also like to mention that Professor Malik was before going to Doha was a professor at Manchester. That's where we met. Okay, and he is the author of the textbook of diabetic neuropathy.
A number of textbooks, yes.
A number of textbooks. Yeah. And I'm so pleased to see you today, and I hope I can have you for another episode.
Shukran, Hani.
Thanks, Professor.
Okay.